I'm going to hit record. That little recording thing didn't come up though.
It says recording on my end.
Okay. Okay, good.
Well, maybe it went already.
Great. Well, I want to be, my goal with these is to be really tight with the time and so that
Okay.
it's not too much of a burden. So let's get right into it. Thank you for all who have joined. I'm super excited to introduce Dr. Kelly Wright. She is a MIGS surgeon at Cedars-Sinai. And really, I think the national expert on this topic of decarbonizing your operating room and also your healthcare system and hospital, because even though operating rooms are 30 to 40% of carbon emissions for a hospital, there's lots of other ways that hospitals can decarbonize. And I know Kelly lectures and thinks about that. And actually, I saw one of her lectures recently, and it inspired me to catch up with her and find out what she's been reading about, thinking about, and doing in this space. So welcome, Kelly.
Yeah, no, thanks so much for having me. And it's great to be in great company with like-minded people, because I think the more that I do this, the more I learn that we all have something to contribute, and that hospitals and administrators really want us as clinicians or frontline staff to contribute. Because even though they're the ones with the process, they don't necessarily know how to do it themselves or have the motivation to do it themselves. So thanks for all of you for having conversations and bouncing ideas. It's a really great community you've built here.
So one of the slides that I was super impressed with that I saw in your deck when I watched your talk was comparing the carbon footprint of, say, an operating room versus that of aviation or a flight, for instance. And I was wondering if you could tell us a little bit, what you say to your audiences regarding, because I think comparing aviation to medical care, it's a good, it presents a good visual.
Yeah, I think it's just reframing our focus, because it's very easy for us to focus on things that create emissions we can see, like cars and planes. And of course, there are problems with that. But because those industries get a lot of scrutiny, you can go online, you can calculate the carbon emissions from your flight. You can put in the type of plane, where it's going, even what time of day you're flying, what type of seat you're flying in. All of those factors actually make a difference in the carbon emissions attributed to you. But when it comes to the operating room, our hospital systems could not measure the same thing for what's going on in their own systems and in their own rooms. And so what I really appreciate is the life cycle assessment that was done at McGee by Cassandra Thiel and Noe Copley Woods and collaborators, that allowed us to begin to see what those emissions look like from our interactions in the OR every day. So if I can just go online and put in a few factors and calculate how much carbon I'm emitting from flying somewhere, why can't I also do that with the OR? Their work is really the first step in distilling that down. And what I found is that, missing 1 or 2 days in the OR is actually much more carbon emissions than taking a transcontinental flight, which is absolutely horrible. But it's really important for us, I think, in healthcare to look inward and change the narrative of the industries that we're scrutinizing.
Yeah, and I'm curious, in your travels, both either virtual or in person, are you meeting either other OBGYNs or even other surgeons that are also focusing on these issues?
Yeah. Oh, and I just saw in the chat, Alyssa said,
Oh, I
sorry to
just let her
interrupt.
in. I just let her in.
Okay, perfect. So you're saying, are we meeting other people who are concerned with these issues?
Yeah, I mean, I know that you recently had a publication in, was it in JAMA Surgery?
Yeah,
Yeah.
yeah. Yeah,
So
and
how
this
are you interacting with other surgeons?
this actually came out of a session that I gave with some surgical colleagues at the American College of Surgeons last year, I'm finding that there is a lot of interest. And so most, some big conferences will put out a call for proposals for sessions. I did one for ACOG, I've done one for AGL, and then American College of Surgeons wanted to do one. It was actually their young surgeon group that wanted to put this on. I got to meet with these other surgeons who are also doing like the same incredible work at their own institutions, just with the lens of whatever their field is, ENT, ophthalmology, general surgery, bariatric surgery. And for that particular paper in JAMA surgery, we were thinking about sustainability, not only from an environmental lens, but also from how does it impact the workforce? Because there were some stats that during COVID, and this came from the last March, there was a National Academies workshop on reusable healthcare textiles. And I can share these links with you. This is all
Oh
the
yeah, yeah.
proceedings are free online. And from that workshop, we learned that during COVID or the early days of COVID, single-use supplies, particularly gowns, surgical gowns and isolation gowns, the cost went up by over 2,000% because of difficulty in procurement. And at that time, that's when healthcare costs really shifted from always traditionally being majority labor to being supplies. And since then, and now I saw something on social media that was like the first week of COVID was half a decade ago this week. I'm like, oh my gosh, was it
No
all
way.
5 years ago? Like it doesn't
Wow.
feel that long ago. But now it's shifted and supply chain is extremely reactive. Costs are extremely volatile and it's no longer reliable. So part of sustainability is also not only environmental, but also shifting focus back to the worker. What do we want to invest in? Do we want to invest in a healthy workforce, or do we want to invest in just trying to keep up with these single-use supplies all the time? And
Yeah.
some of that was coming down to like SPD, our sterile processing units, who are often some of the lowest paid workers in the hospital, but not making investments in them. So not being able to keep up with good, high quality, reusable equipment to keep that for us, to provide excellent patient care without supply chain disruptions. So it all really goes together, the environment and then the people who interact with us in our systems.
Yeah. I haven't heard hospitals talk about having preparedness for supply chain collapse in to the degree that they need to, given what we saw with Baxter and the IV fluid shortage. In the same way that I feel like we haven't necessarily seen the movement that we would like to regarding the environmental, like addressing it as a decarbonization strategy. Maybe there's more appetite within healthcare systems to address carbon and supply chain adaptation.
Yeah.
Well, and if I'm gonna add 2 cents here. I had a
Yeah.
conversation with somebody today, and he was telling me how 5 to 10 years ago they got rid of all of their stainless steel reusable specs, and then moved to plastic as well as metal specs that can be thrown out. And it was they had told them when everybody's like, why in an uproar, like, oh well, it's just cheaper, like it's too expensive to, it's too expensive to sterilize. Um, and like articles are finally coming up that are demonstrating that's not true. Like, people say
Yeah.
that all the time, but like when you actually crunch the numbers in an LCA or LCC fashion, it's not true. But I couldn't really talk him out of it. We like talked about it, but he was like, yeah, that's what they said. So just on that note, like we need more like cost analyses and especially for specula in our field, because that's the common denominator. I feel like so many triages and L&Ds like have plastic specula, and they're like, well, it costs even the nurses take their time to have to bring their stuff down to central sterilization. But we don't have those numbers. So
Yeah. And
hopefully
if
we
you
can get those
go
numbers.
And if you
Yeah.
go to Wyeth, who makes the clear green ones, if you go to their website, they'll tell you that their plastic speculums are cheaper, but of course they haven't included the disposal, and they haven't obviously included the healthcare costs of the plastic exposure, like we saw with Dr. Treson's article showing in 2018. The human healthcare costs of plastic exposure over $250 billion in healthcare costs. And we saw that article coming out of SMFM just 2 months ago showing that placentas that had of preterm births had more microplastics in them than the term births, which was not what the researchers were expecting to find. So I do think, nobody is accounting for the healthcare costs of all the plastic.
Yeah,
Agreed.
100%. No one's accounting for, so value analysis committees, they're doing a terrible job. They're doing it on purchase price. So like price on the shelf. Sometimes they're not even including shipping, and they're 100% not including the cost of disposal, use, or the dispose of all the packaging. And so you just hear these scripts, right? These scripts that we're all told, oh, there's nowhere to store this equipment. It's like there's nowhere to store the incoming supply of single-use supplies that it takes to replace one stainless steel instrument. And that can be an issue for the clinic too, where space is so limited and like, oh, we don't have anywhere to put these speculums. It's like, no, we don't have anywhere to put a box of 1,000 disposable speculums at a time,
Right, yeah.
So I don't think when I try to have tried to understand priorities, it's like, okay, I tried to outline it for Harvard School of Public Health like this. It's theoretical patient safety. Yes, we want patients to be safe. But we don't necessarily have evidence or follow the evidence for what is the safest. We are doing what is perceived as the safest. Theoretical patient safety, theoretical cost savings. Again, this sounds like it's going to be cheaper. Maybe we're being marketed and told it's less expensive, but the truth is once you do that LCC, for sure it's much more expensive. So it's theoretical patient safety, theoretical cost savings, actual patient safety, and then cost savings. And then probably way, way down is like staff safety, which is also extremely expensive for hospitals, but not something they necessarily consider. So again, I think most hospitals right now are being extremely reactive in all of those scenarios and not being proactive. And like Ali said, I think it will take us publishing more and more and more, both on the cost side and the human health effect side, before things will start to shift towards that actual like evidence.
Yeah, one of the questions I want to make sure I got into was if you saw or heard any conversations since the fires about the relationship between climate change and healthcare, or whether people are just kind of getting through the next few months.
Gosh, I don't think anyone locally has processed it to the extent that it affected us. But I can say that, I mean, it was a horrible time here. But even so, and people ask, what did it feel like? It felt like when I used to live in Boston, it felt like a snow day, like a snowstorm day or snow emergency day. But where if you went outside, like the air would kill you, in a very like macabre way. But we actually had to close the ORs for 2 days because there was so many, there was so much, what am I trying to say? Oh yeah, there were so many people who were evacuated that we couldn't count on staff coming in to actually staff the hospital. So that alone, the hospital's losing revenue big time because we had to cancel elective cases. And then there was a health risk. What do we tell patients? And nobody in the moment really knew, except like stay inside, get air filters. But it's different than traditional wildfire risk because it was homes. So then the long-term question, and I asked many of the environmental researchers at the Harvard School of Public Health who are currently going to be researching pregnant people for the next 9 months to look at the effects of what happened. But also, if this is more industrial fire, and so there's much more chemicals in the air, then what does that mean longer term? What does that mean as far as how we think about air quality and when it is actually safe to go outside? So it was a very heavy time, but it's not something still that the hospital, it's not something still that healthcare is taking accountability for contributing to.
Yeah.
Say across the board. We can talk about how it affects us and our patients all day long, but still nobody's looking inward to say, hey, we're a big contributor to this actually.
And if that wasn't a moment of reflection to connect those dots, what could be? Because that was so big.
It was so big. I think what we have to do right now is still compare to industries that are bad, right? So compare ourselves to other industries that are bad or being studied and say, hey, wait a second, we produce more emissions than they do. There's lots of papers on how traffic-related air pollution affects cardiac events, affects
yeah.
weight loss after bariatric surgery, how it affects this or that. But to say, hey, did you know that the pharmaceutical industry creates more emissions than auto manufacturers? Why aren't we looking at them? I do think from our journals and our publications that we are seeing a nice level of interest or a shift. So JAMA surgery, or JAMA in general, JAMA surgery and New England Journal. I was really pleased to see when New England Journal last year had that perspective where they said RCTs should include life cycle assessments.
Yeah.
Because no one cares if something is non-inferior, if it's actually creating so much more emissions that it's going to harm human health in that way. And I think that was a really wonderful first step for us to think about our healthcare interventions. We should be applying LCAs to all of them. And there is a wonderful website called healthcarelca.com. If somebody tells you something, you can just go to it and look it up and see what the actual impact is of that process or that instrument. But I thought that was a really nice call. And I feel like our journals and our societies are leading the way more in this right now than our hospital systems. In our hospital systems, everybody is doing siloed work on the ground, and there are lots of great people doing great work on the ground. But as far as a coordinated, massive effort across a system, we haven't seen a leader jump out in that, I think, in hospital systems or in medical device manufacturing yet. Because that's the other question I get. Oh, who's the good medical device company? Well, there
Are you or Allie, are either of you seeing are either of you getting traction with medical device companies paying attention to what you guys are talking about?
I mean, honestly, no. I mean, I've had some companies approach me to like want to research a little bit more. So maybe to your question, yes, but I haven't seen anybody like want to change how they're making and manufacturing instruments. I am hopeful, fingers crossed, that one of my pieces is going to come out pretty soon, and hopefully one of the devices won't be too angry. But I'm hoping that it's going to be well read and widespread, and that it will encourage conversation because it is a big deal. Like we need them to do some of the work too. But to your question, and then I'll let Kelly chime in. I think that what we also need to talk about is that there's so many, like so much of what we purchase and use is dictated by contracts. And I'm like finally sitting on a committee that was looking at like different devices and what we can and can't use. And it's not just for our institution, other institutions use what we use. And it's not a very big group of people. Like, wow, we are making so many decisions for so many physicians. And I'm, providing that voice, but it's hard when they're, a contract with potentially, for example, like Medtronic, like it's not only Gyne stuff that they sell all this other stuff and you can't like upset them. And that is very illuminating to me. So it's like these changes are being made by a few people, but they're so much bigger than what we think, and it's so much more nuanced. And a study even came out. I don't know if it was the New England Journal or another journal, but like these sourcing committees and contracting committees are so different, like the way that they look everything, which device, if they're just looking at one specialty versus hospital wide, system wide, like some huge systems like Kaiser, I'm Cleveland Clinic, like I'm sure that contracts are for all the hospitals, and that is hard to break into. And that dictates a lot of our care. So like, not only do we need to be doing the work, and of course industry needs to make some changes, but we need the people on those committees to really understand this too.
Yeah. And I would say, so I've met with multiple major medical device companies. I met with Intuitive yesterday, so it's top of mind. Hell froze over. They wanted to meet, but they said, and this is probably true, they said, we need to survey surgeons because we're not going to do anything unless there's an appetite for it. So I think our message has to be unified that the surgeons are tired of all the waste. We're tired of all the plastics, and we want high quality, reusable instruments because they're reliable and they're there and we're not going to run out. I mean, we've had examples of supply chain shortages from Medtronic, from Cooper, from Baxter, whatever the cause, we've had supply chain shortages and we're tired of having to be reactive in our care. So that's number one. Our message to the manufacturer has to be unified. And I think the medical societies like American College of Surgeons is working on that now. Number two, the manufacturers that are working on sustainability are doing more on their procurement side. So they're not doing anything with the end user. So in Europe, they'll make their device reusable, but in the US, they're going to sell their single-use supplies because that's where they make their huge profit margins. So maybe they have really streamlined their manufacturing and gotten LEED certified buildings. And so they're doing this. They have more streamlined shipping. So they're working on the procurement side, but once it's handed off to us, they essentially take no ownership. And even Intuitive said, like, we don't track. Once it's sold, like, we don't track what happens to it. And so essentially all of that cost and waste and environmental burden is just shifted onto us in healthcare. And then we're the end users and the disposers. And that needs to change, kind of that pushback, say, this is a huge cost for us. We can't throw this away anymore. We can't carry your product. That pushback on the manufacturer that they actually need to trace the full life cycle of what happens to their devices if they're actually going to say that they have carbon reduction goals and meet those goals. So that's kind of what I've been thinking about the manufacturers as far as what
So,
they're doing right now. Yeah.
we could put together a Google form, and we have our 7,000 OBGYNs over on OMG, and it could be simple. It could be like 5 questions, so it wouldn't take too much time, but we could ask people if this was something that they were worried about and they were
Mhm.
concerned about. And then maybe if we got, like, I don't know, 500 people, and then presented it to the device manufacturers.
We could even publish it. I mean, Sages published a survey that they sent to their own surgeons a few years ago. I think it was over 90% buy-in, or said that they would change their practices if they could make a dent in carbon emissions, and if they knew what they were using, if there was like apples to apples comparison. So yeah, it'd be something that could be published.
Okay, well, I'm down with that.
Perfect. Done.
I want to be cognizant of your time. Let's see. Talk to us a little bit about your opinions about you work or in the same department with Melissa Wong, who's a national expert on AI and healthcare. Tell us a little bit about your thoughts about that.
Oh man, I'm definitely not an expert in this, but I'm trying to dip my toe in the water because one of the themes of AEGL this year, I was on the board, so it's my main organization, but AI is going to be the big theme this year. And one of the things I suggested was when you do sessions about pros and cons, one of the things that has to be brought up is the intensive energy use.
Yeah.
And that needs to be distilled down because none of us think about computer systems, the cloud, as contributing to an environmental footprint. But it's those comparisons again, understanding what is the difference between a simple Google search and then a Google search that incorporates their language, I think it's the language learning model into the results that they give you. It's actually a huge difference in energy usage and emissions. And so I think if people just knew, there's no transparency here at all. And if we think about why did South Korea say that no one can mine blockchain anymore? Why is Greenland a country of interest right now? And it's because of the geothermal energy to power these servers essentially that are serving us machine learning and AI. So the first step in this is just awareness.
Yeah.
It doesn't even have to be, this is bad. It's like, you just need to know the comparison. You just need to know exactly what's going on.
Yeah. Do the math, know the math.
Yeah.
When is AAGL?
November this year in
Oh, okay. You've got a
Vancouver.
while.
Yeah.
Will you be there as well, Allie?
I don't know. I didn't realize it was in Vancouver. They're both AUGS and AAGL are in Vancouver. That's very far from Cleveland, and it requires multiple planes.
Yeah.
It's very far, but we're so happy to support our Canadian
I
colleagues. But
know.
actually, I love the Vancouver Convention Center because it's
fun.
one of the only convention centers that it's LEED certified. They have a green roof, so it's grass on the roof. Their components are like they serve compostable utensils. So it's actually one of the greenest places that we can have a conference. And so I always
Yeah.
appreciate it every few years when we go up to Vancouver.
Yeah. It
Yeah.
was beautiful in 2019. It was great. That
Yeah.
was the last one I went to before COVID.
Yeah. Yeah.
I have a question though. So speaking of, AI on Google, not something it just showed up one day, right? It's just like now
Yeah.
every time you search, it gives you the AI. Can you turn that off? Or should we all play around with Google?
Yeah, actually, if you're doing a search, even in your search bar and you just type minus AI at the very end
Mhm.
of it,
Yeah.
it won't do it.
Wow.
Yeah.
People need to know that. I need,
Wow. Yeah, I
hopefully
Yeah.
didn't know.
everybody in this call, like, because if you're looking for, I don't know, gas prices in Canada, I don't know, like, you don't need AI. Like, it'll pop up for you.
Right. You just need material that's already indexed. And what Google's trying to do right now is with all these searches, because the servers are still learning. So it's still in the learning phase. That's when they say like,
Yeah.
and Ali, you and Jane, you two probably know more about this than I do, but what I've learned is that when it's in the like learning phase, that's when it's using the most energy. And so Google
Yeah.
just put it up there and made it show up so that their machines can learn from your
Mhm.
searches. And so that's why so many of them are wrong. Like when you click on the page, actually the
Yeah.
information is not interpreted
Right.
correctly. So for now, like turn it off. Most of us didn't intend, if you intend to use AI, go to Chat GPT and use it. But the way it's being inserted into our everyday lives, we should have a little bit more transparency and control over because that's part of our
Mhm.
carbon footprint.
Yeah. No, that's
100%. Yeah. And I think that people don't know that. And I'd be curious. Yeah, I have some friends who work in tech and they're like, AI is all the rage. I have not had a chance to talk to them about this. Like, well, what are you doing about the carbon footprint?
Yeah.
We'll have to see what they say. Stay tuned. I'll fill you in.
Yeah.
We're
Yeah.
almost at time. Does anyone that's listening have a question for Kelly? Come off mute, raise your hand.
And I'm also happy to the talk that I just gave that you saw, Jane, they put it on a link, I think like a YouTube link. So I'm happy to share that so
Oh, very cool.
you all can see
Okay,
the
great.
actual presentation.
Yeah,
Yeah.
that was
Thanks,
really
Kelly.
good.
Yeah.
For
Always good to
facilities
see
that are
you.
in infancy in terms of moving our ORs, some of them are a little hard to move. What do you look at as low-hanging fruit?
Oh, that's a wonderful question. One of the lowest hanging fruit in new facilities, typically in building, that can save a ton of money for the hospitals, not directly related to us, but to anesthesia. And that's not building in or not using the nitrous centralized piping. So nitrous, as you all know, very, very rarely used clinically. It has a super low boiling point. So when it's stored in big containers and run through lines throughout the hospital, it just continuously leaks out throughout the day. So it's really cheap gas, so the hospital doesn't notice the loss financially, but of course it's a terrible greenhouse gas going into the atmosphere. It's much better used point of care in small cans, whether that's on L&D or for pediatric anesthesia cases, and can be brought to the OR again for point of care. So those lines can be decentralized, but if you're actually building out new space, not building in those lines saves tens of millions of dollars. So it can be
That's so
substantial.
good.
Yeah. That's probably the number one biggest thing if moving ORs. Maybe the second biggest thing is LED lights and HVAC setbacks set on automatic
No.
timers or timers that are aligned with the OR schedule. But kind of an easier fix for that is just training your environmental services people to turn off the lights and turn up the temperature in what's called the terminal clean, like the last clean of the day. So there's easy ways to do that too.
Yeah.
Yeah. Great question.
Yeah. What about desflurane? No desflurane.
No desflurane. So this is interesting. Allie talked about contracts. Our anesthesia department found out that the contract that they had was that for every desflurane vaporizer that they had on an anesthesia machine, they had to buy so many bottles of desflurane. They were not using about $150,000 worth of des a year, but the contract required that they bought it because of the vaporizers. So all they did was go around and get rid of the vaporizers. They no longer
there
had
you
to
go.
purchase
Yeah.
the desflurane. And then an anesthesiologist could get a vaporizer, hook it up and use it if they really wanted to, if they felt it was indicated. But it saved a ton of money to undo that contract just by not having the vaporizers. Isn't that
Well,
fascinating?
Alana,
Everything's money.
yeah.
It
Alana
is.
has a good
It
question.
is money.
Alana has a good question. How do you go about initiating conversation? I would say invite Kelly to give a grand round at your facility. And she will get the conversation started for you.
Alana, that is a great question. And it's actually something Allie and I were just talking about writing up as a process, because some of the biggest questions we get are, how do you get started? And when I think back, I'm like, oh man, how did I get started? I just annoyed people for 2 years, but there must be a better way. And so I think, and we'll write this out more eloquently, but it involves gathering frontline stakeholders. Who's interested? If you're a medical student, and I'm not sure if that's what M2 means, but who of your faculty are interested? Who in the operating room of the nurses and the scrub techs are interested? And then going that next level up to get stakeholder buy-in. Who of the nurse educators, the OR managers are interested? Who in environmental services and supply chain is interested? And then again, going that next level up, because we need to involve people like safety officers. So it actually is a lot of people that it takes to make these projects happen. But once you get one small project in, they do tend to steamroll and they can take on a bit of a life of their own. So that's the positive part about all the work up front.
I agree. And I'm just going to add to that, when you are talking to these people, whatever idea you have, whether you're just trying to look at like open and unused items in DNC trays, for example, have some data to discuss with them ahead of time, and then some ideas about maybe what kind of project you want to do, and talk to them before like making a QI project. And then have your stakeholders, at least some of them, on board while you go through that process. I will say that Kelly might have had a similar experience, but we tried to roll out a project without formalizing it as a QI, and people were like, no, we're not doing this, like patient safety and a lot of other things. So then we made it a formal QI. We went all the way up the chain, like Kelly's talking about. And then they had to. It was like, okay, well, if it's been, approved, I guess we'll do it. But our mistake was like not, like some people were interested, but not all the right people. And we didn't formalize it before we just did it. And so I would formalize it, and then it'll be nice to have that data. And then especially if you're in training, it's great to contribute to the data in this field, and then you can present it and publish it and all that. But not formalizing it can be tricky.
That's a really good point. Really good point.
Great point.
You're welcome. Well, Kelly, thank you so much. I know you're
Thank
traveling, right?
you. Oh no, I'm down at Sages in Long Beach, so
Okay. Okay.
So
Great.
not much.
not too
So
far.
people are traveling
That's
to
fine.
you.
All
I
right.
mean, it's traveling like going like commuting, but luckily, I'll do that a little later.
All right. Well, we're excited. We're going to interview Tracy Woodruff next week. And we're going to talk about plastic.
Oh boy.
I'm sure everyone saw the article showing that there's plastic in all of our plants, and it could be contributing to hunger worldwide.
Oh.
And more to come as our plants are taking up plastic, and it's preventing chlorophyll from doing what it needs to do. And yeah, could mean the collapse of the phytoplankton, because they, are the basis of the ocean ecosystem.
It'd be interesting to learn more. We always need our environmental health people to tell us like what happens at the end point, and then we need to reflect on that and then turn it into something we can take action on.
Absolutely. All right. Well, we will get that form circulated. I like that idea. That is a great action to take away from this great conversation.
Thanks so much for having me.
Bye.
Yeah, awesome. Always good to see you. Take
Yeah,
care.
good to see you, Allie.
Thanks.